Relapsed acute myeloid leukemia is a dismal situation with a very dismal prognosis. There is no standard therapy for patients with relapsed AML that is FDA approved. By default, physicians use cytarabine-based regimens, and many of the trials that have been conducted have used high doses of cytarabine as the standard of treatment, and this is why we randomize patients to receive either high-dose cytarabine or cytarabine plus buzzeraxin.
Can you tell me about buzzeraxin? What is it? What does it do?
Buzzeraxin is a new quinolone derivative. It's a first-in-class anti-cancer quinolone derivative. So it's related to a commonly used antibiotic, ciprofloxacin and other quinolones, in terms of its structure. But it's been shown to be active, highly active in cell lines and primary AML patient samples, and has also been shown to be synergistic with cytarabine, again in preclinical studies.
And interestingly, potentially less cardiotoxic.
The interesting features of the drug are that it is not a P-glycoprotein substrate, so it does not get extruded from the cells, and it does not work based on the P53 mechanism, and also it reduces, it has limited production of reactive oxygen species, which reduces its potential for cardiotoxicity. It is a topoisomerase II inhibitor, and this is why it is commonly compared with anthracyclines and other topo-2 inhibitors, and we all know that those agents are associated with significant cardiotoxicity. As such, these characteristics make the drug an interesting drug for AML, and particularly relapsed AML.
And it's a big study, over 700 patients.
711 patients randomized on the two arms of the study.
The primary endpoints?
The primary endpoint was overall survival. The secondary endpoints were complete response rate, as well as toxicity and event-free survival, the number of patients who went on to have a transplant, etc.
Now, response rate is pretty crucial in a study in this category of patients. What were your results?
The complete response rate was 30.1% for the buzzeraxin arm, as opposed to 16.3% for the control arm, which was a highly statistically significant advantage for the treatment arm.
Now, did you break that down in terms of the age of the patients?
The response rate was very equivalent in both younger and older patients. I don't have the exact numbers.
So what did you find overall in the study?
In overall, this is a effective regimen producing high response rates, which does translate to an improved overall survival and is not associated with higher early toxicity and early mortality.
Now, it did have an impact on allergenic transplantation, didn't it?
There were a bigger proportion of patients who achieved CR on the buzzeraxin arm and underwent an allergenic transplant. However, overall, the two arms of the study were equivalent in terms of proportion of patients who underwent allergenic transplant. Obviously, patients who were younger had a higher rate of post-treatment allergenic transplant, which was about 45% for both arms of the study. In the older patients, it was about 20%, which is what is expected.
So what are the most important findings that you would draw attention to coming out of this?
Again, the most important finding is that the combination is associated with a higher CR rate and a highly significant survival advantage in patients over the age of 60.
What do you think could be the clinical implications?
I believe, based on the fact that there is no standard for therapy of relapsed AML, that this study has clearly demonstrated that the combination of cytarabine and buzzeraxin is superior to cytarabine alone and should be the new standard in all the patients with relapsed AML.
Okay, and that would be your conclusions, basically, would it?
That is my conclusion.
Bottom line message for doctors to take home?
Combination of buzzeraxin and cytarabine should be the new standard in relapsed patients with AML who are older the age of 60.